Hello, everyone. My name is Haidira del Rivero. I am a medical oncologist and also a clinical endocrinologist at the National Cancer Institute, National Institute of Health. Today, we're going to discuss a study for a rare neuroendocrine tumor called pheochromocytoma and PARAganglioma. And this is a study of lanreotide in metastatic pheochromocytoma and PARAganglioma. We also call this study LAMPARA. And just to explain what is LAMPARA is just a combination of different words within the title of the study. So LA is for lanreotide, M is for metastatic, and PARA is for pheochromocytomas and PARAganglioma. So that's the name that we use here. Even when we refer to the study, we also call it LAMPARA, just to make it a little bit shorter when we discuss the study. So why we wanted to do this study and what is the rationale of the study? Pheochromocytomas and PARAgangliomas express somatostatin receptors similarly to other neuroendocrine tumors or even higher than other neuroendocrine tumors. Expression of somatostatin receptors can be demonstrated in metastatic or recurrent pheochromocytoma and PARAganglioma. And this has been demonstrated by uptake in different imaging modalities, such as 68 gallium or 64 copper dotatate scans. So this is a picture of the different functional imaging modalities that we use in a patient with pheochromocytoma and PARAganglioma. Some patients with pheo and para, we obtain an MIVG scan, and if the MIVG scan is positive, patient can be eligible for MIVG therapy. If the patient has a positive dotatate scan, that make the patient eligible for the therapies, including 177 lutetium dotatate. But this imaging is also tells me how the 68 gallium or 64 copper dotatate scans are extremely good imaging modalities that can definitely detect all tumors associated with this tumor type. And we recommend that every patient that has pheo and PARAgangliomas needs to obtain a 68 gallium or 64 copper dotatate scans to help us also to understand about the staging of this tumor. And we're going to discuss a little bit more in another slide. Something that I would like to mention, if you would like to learn more about pheochromocytoma and PARAganglioma, I will advise you to go to the LACNETS website. There's a lot of information there about pheochromocytomas and PARAgangliomas as well. There is a video that I was fortunate to be part of discussing all about pheos and paras. And also there is the Pheo Para Alliance, who also have a lot of information about this tumor type. Now, as we discussed earlier, that the 68 gallium or 64 copper dotatate scan is a good and even an excellent imaging modality for diagnosis, but as well to staging. Staging, it means that we wanted to understand how many tumors are in the body that sometimes we're also unable to see with other imaging modalities. And also help us to understand that by doing this type of imaging, whether the patient may be eligible either for MIVG or for Lutathera. Here we are in this picture. I'm just explaining about pheochromocytomas and PARAgangliomas express somatostatin receptor in the surface of the cell. And I would like to use the analogy of Dr. Kunz of the key and lock analogy, where the receptor is the lock, and then you have the key, which is the linker of the targeted ligand. And once you're trying to open that lock, there is going to be a series of events. And with that, it is important because if we have a tumor that expresses a somatostatin receptor, once you do the dotatate scan, it goes directly and bind to those receptors as well as the therapy. And here below, we can see the different sensitivities of pheochromocytomas and PARAgangliomas, meaning of the tumors, what are real in terms of metastatic pheo and para. And we can see here that the 68 gallium dotatate scan is the highest to detect tumors related to pheochromocytomas and PARAgangliomas. And because of that, we use it as a diagnostic tool. And every patient that have pheo paras, we now recommend that at baseline, we need to obtain a 68 gallium dotatate scan. Now, this is just very briefly about somatostatin agonists. I want to say that if you have a positive dotatate scan, similarly to neuroendocrine tumors, they can either get injections once a month of lanreotide or octreotide, or they can get 177 lutetium DOTA as long as we have a positive DOTA scan. Here, this is just to show you a little bit of what these monthly injections are, either sandostatin or lanreotide. And we can see that both of these studies show that there is a benefit in stabilizing the tumor. As we can see here, this is just a graph that sometimes we explain to patients, where this is the y-axis is the proportion of patients, and the x-axis is the duration of how this drug can stabilize the tumors. And we can see here that either sandostatin or lanreotide, we can see that in neuroendocrine tumors, they can stabilize the tumors and prevent them from growing. And because of this information, we has been extrapolating this information to use it also in pheochromocytomas and paragangliomas, because this is also a type of neuroendocrine tumors that also express the somatostatin receptor. And because of that, we wanted to also understand what is the therapeutic effect by giving lanreotide in patients with pheochromocytomas and paragangliomas. There has not been any prospective study, meaning to understand what is the benefit prospectively, and that we follow these patients to understand the efficacy over a certain period of time. And we really wanted to understand whether lanreotide can has the effect that can also stabilize the tumors as with the other neuroendocrine tumors. Now, many physicians are recommending these injections as one of the first line, but the study is helping us understand whether this medication will have the effect as we have seen with neuroendocrine tumors in stabilizing and preventing growth of these tumors. This study is together with Dr. Tito Fojo. He's at Columbia University Medical Center, who came with the idea of having the study for patients with pheochromocytomas and paragangliomas to understand whether we see the same efficacy in stabilizing the tumors as we have seen with neuroendocrine tumors. And because of that, one of the questions that we want to answer, but that running the study, if it can stabilize the tumors within a certain periods of time. This is just another graph, and I know sometimes it can be difficult to understand, but this is just the different growth rate. And just very briefly, we can see that these are different studies. This was the study with lanreotide in neuroendocrine tumors. It also include a few patients with pheochromocytomas and paragangliomas. And Dr. Fojo was able to obtain that information and then also understand what is the growth rate. As we can see here, the patients in blue is patients that got placebo, because on the lanreotide study for neuroendocrine tumors, which also includes very few patients with pheochromocytomas and paragangliomas, they were randomized either to receive lanreotide or placebo. And we can see these in blue, the patients that receive placebo versus the patients in green that receive the lanreotide. And just to explain very briefly that a lot of the patients did stabilize the tumor growth compared to placebo. And because of that, this is the question that we wanted to answer, whether lanreotide can also slow down the growth or stabilize the growth of patients with pheochromocytomas and paragangliomas. Other questions that we wanted to answer by doing the study is whether we can see any response rates, whether it can shrink some of the tumors. We have seen that with other neuroendocrine tumors that may not be likely the case, but we see stabilization, which is still stabilization is still a good thing in these clinical studies. We also wanted to understand whether it can also stabilize the growth for certain periods of time, and whether by using this treatment, could this treatment make you live longer. So, and that's the reason why we wanted to do the study. We are enrolling patients at the clinical center, and this study can definitely help us understand and get it approved by the FDA for the indications to treat patients with pheochromocytomas and paragangliomas. And with that, I would like to finish my presentation. And I always like to end with individually, we are one drop, together we're an ocean. It takes a village and to understand more about and develop better therapies for these neuroendocrine tumors, especially these rare neuroendocrine tumors such as pheochromocytomas and paragangliomas. I would like to thank our real heroes, which is our patients and caregivers. And if you have any information, please don't hesitate to reach out. Here's my email, and I'm happy to answer any questions or provide more information about this study. Thank you.